Good morning. We are in the second day of our course, and we have two distinguished chairpersons and many distinguished speakers. So today's topic is about the role of CMR in non-ischemic cardiomyopathy. I give the place to chairpersons. Open microphone.
So good morning, Sophie. It's a pleasure being invited again to this wonderful meeting, international meeting, CMR Athens CMR. And we start today with a very important topic of CMR application and research, which is dedicated to myocarditis. May I invite Dr. Tsoumani for the lecture CMR in Myocarditis.
Good morning. I would like to thank the organizing committee and especially Professor Mavrogeni for the kind invitation to participate in Athens CMR course and give today a talk about CMR in myocarditis. Myocarditis refers to the inflammation of the heart muscle. It can predominantly caused by viruses, but can also be triggered by drugs, toxins, can be cancer-related or autoimmune-related. It affects around 22 cases per 100,000 of the world's population. It has a male prevalence. It is the fourth cause of sudden cardiac death, found up to 12% of the postmortem studies. The clinical presentation of myocarditis is quite heterogeneous, with symptoms range from mild or no symptoms to infarct-like chest pain, arrhythmias, heart failure, sudden cardiac death. In acute myocarditis, diagnosed by endomyocardial biopsy, up to 50% of the patients may have a spontaneous recovery, but up to 25% may have a persistent reduced function. 10 to 25% may have a gradual LV dysfunction that could lead to end-stage dilated cardiomyopathy, heart transplantation, or even death. In the recent 2025 European guidelines for the management of myocarditis and pericarditis, the umbrella term inflammatory myopericardial syndrome was introduced to guide the initial diagnostic process until a final diagnosis is reached. The initial workup includes a physical exam, ECG, lab values, echocardiography, followed by ruling out obstructive coronary artery disease, either using coronary computer tomography or invasive coronary angiography, according to the clinical likelihood. Based on the case and on the individual case and risk, definite diagnosis of myocarditis can be done using CMR or endomyocardial biopsy. The latter can identify the underlying etiology, guide the management through immunohistochemistry, however is an invasive method prone to false negative results, has low sensitivity, and is mainly reserved for high-risk cases. On the contrary, CMR has evolved over the years and has emerged as a non-invasive biopsy-like method that can both detect and exclude myocardial inflammation. This is especially relevant in cases involving the epicardium, pericardium, or other regions that cannot be accessible to biopsy. In the same exam, assessment of alternate diagnosis responsible for the acute presentation can be made. So today we have a paradigm shift in the diagnostic process of the myocarditis with CMR CMR has shaped the clinical process in such a way that in 2013 CMR could raise the suspicion for myocarditis, but today in 2025 CMR can provide a definite diagnosis or reject the diagnosis of myocardial in a strength similar to the one from biopsy. And this comes with no surprise, as we know that CMR is a safe, non-invasive technique using non-ionizing radiation, has high spatial and temporal resolution. It can accurately measure volumes and ejection fraction of the cardiac chambers, independent of body size or acoustic windows. It is already considered the gold standard for right ventricular assessment, but most importantly, can provide us with unique tissue characterization information. So the protocol targets to assess the ventricular volumes and function, identify regional wall motion abnormalities, detect inflammation, scar, assess pericardium that is often involved in myocarditis, and exclude other causes for the clinical presentation. The main works of CMR is the SSFP sequence that allow us to assess the structure and the function of the heart, calculate volumes, ejection fraction, identify regional wall motion abnormalities, identify whether there is pericardial effusion or not. T2-weighted short stir imaging is quite sensitive in the increase of water content that make it really useful in detecting edema, especially focal edema. Focal edema can be visualized on T2-weighted stir imaging as areas with increased signal intensity within the myocardium that are mainly subepicardial or mid-wall, but can spare the subendocardial, except for when the inflammation is so severe that can be almost transmural. On stir imaging, we can assess also if there is inflammation of pericardium, which would have be seen as a bright line circumferencing the myocardium. We can also calculate a ratio when compare the signal intensity of the myocardium with the signal intensity of the skeletal muscles not seen on this image, and then we can have a ratio which, if it is equal or higher than 2, is really suggestive of the presence of edema. We have to bear in mind the evolution of edema that tends to become more diffuse and declines around 4 weeks after the symptom onset. So we have to prescribe to order CMR in the first 2-3 weeks after symptoms onset. T2 star comes with technical limitations in terms of low signal to noise ratio, artifacts from prolonged acquisition times, slow flow artifact on the endocardial border due to limited blood suppression, but most importantly, T2 stir relies on regional differences. That means it's quite problematic when the myocarditis transits from acute to subacute, for when the edema, the inflammation becomes more diffuse, more homogeneous, so we cannot see these discrete areas within the myocardium anymore. Some of these limitations have been overcome with the introduction of the parametric mapping. Gadolinium quickly distributes into the intravascular and interstitial space. So we can see areas of increased signal intensity shortly after giving gadolinium on early gadolinium enhancement sequence, reflecting the hyperemia, the increased vascular permeability, the expansion of the extracellular space, and we can quantify this at a similar way as we do on the stir images by comparing the signal intensity of the myocardium with the skeletal muscles. An early gadolinium enhancement ratio of equal or higher than 4 is highly suggestive of edema. On the late gadolinium enhancement, we can then detect areas of injury, myocardial injury, necrosis, or scar. The distribution follows a non-coronary territory one. It's mainly subepicardial or can be mid-wall, commonly in a linear configuration, sparing the subendocardium, or it can be more patchy-like, or even diffuse. The most common affected area in the myocardium is the basal inferolateral wall, which most commonly seen in the viral myocarditis, followed by mid-inferolateral, basal mid-inferior wall, or even basal aderoseptum. All these CMR findings of myocardial inflammation have been introduced into the original Lake Louise criteria that was initially validated in 2019 and targeted the myocardial inflammation by detecting edema on T2 weighted stir imaging, hymeremia on early gadolinium enhancement, and necrosis or replacement fibrosis on late gadolinium sequences. If 2 out of these 3 criteria are met, then there is a high likelihood of myocarditis, of active myocarditis. These criteria have a good diagnostic accuracy of 83%, have a good specificity, but they lack good sensitivity, especially to detect more diffuse inflammation. Over the years, there has been substantial progress in the development of parametric mapping that allows direct quantitative measurement of the myocardial T1 and T2 relaxation time in a pixel way. So, in myocarditis, the inflamed myocardium exhibits high T1, T2, and ECV values. On T2 map, this can now be reproducibly quantified, not only focally, but can also detect the global edema, overcoming the limitations of T2 weighted stir imaging. T1 map, in contrast, T1 map and ECV map, in contrast to the late gadolinium enhancement, can better show us the interstitial fibrosis, which is a limitation to late gadolinium enhancement. Several studies tried to explore the importance of parametric mapping in detecting in the diagnosis of acute myocarditis. Just to name a few, this one from Ferreira showed that the T1 map, here highlighted with yellow line, has an excellent diagnostic accuracy, better than the T2 weighted stir. In the MyoRacer trial, in patients with acute symptoms, the area under the curve for T2 mapping and T1 mapping, highlighted with blue and red respectively, is higher than the area under the curve for the Lake Louise criteria, for the original Lake Louise criteria. In patients with chronic symptoms, only T2 mapping, as highlighted from the blue line, has important diagnostic association. So, so we can use parametric mapping to help us in suspected myocarditis, for the diagnosis of suspected myocarditis, in a better way than the original Lake Louise criteria, irrespectively of the scanner field. So in 2018, the original Lake Louise criteria were revised, incorporating T1 and T2 mapping, removing the early gadolinium enhancement. So now the diagnosis of myocarditis is based on the presence of evidence of myocardial edema, either on T2 mapping or T2 weighted images, combined with evidence of non-ischemic myocardial injury as evident from abnormal T1, ECV, or late gadolinium enhancement. The combination of these two criteria offers higher diagnostic accuracy, improving the lower sensitivity of the original Lake Louise criteria. Even standalone T1 or T2 criteria has a good sensitivity and specificity in the proper clinical context. Although not mandatory for the diagnosis, supportive criteria for the diagnosis of myocarditis include pericarditis and systolic LV dysfunction. Let's see now how the revised Lake Louise criteria have impact on the in our clinical practice. This is a common scenario. A 23-year-old male with chest pain, ST elevation on lateral wall on ECG, high troponin and recent lung infection, had an MRI 6 days after the symptom onset. So on CNA images, we can appreciate it that the ventricles are not dilated. The ejection fraction of the left ventricle is at the lower limit of normal for the age of the patient, and someone might advocate that there is a subtle hypokinesia of the basal inferolateral wall. On T2 weighted STIR images, we can appreciate that there are regions of increased signal intensity within the lateral wall and the basal inferior wall that were confirmed on T2 mapping, where we can see these yellow areas. T1 mapping has also detected the inflammation by the increased T1 values in the basal inferolateral wall. Early GAD sequence has showed again the same regions with high signal intensity, and now on the late gadolinium enhancement, we can see that these areas are to the subepicardium, involving the basal and mid-inferolateral wall, as well as the mid-inferior wall. So we know that myocarditis caused by virus have a mortality of 19% during 5 years. So scar, many studies have shown that scar, as detected by LGE, is a strong independent predictor for all-cause mortality, cardiac death, and sudden cardiac death. It looks like that ejection fraction is another strong predictor for prognosis in myocarditis. Patients with ejection fraction less than 40% have a worse prognosis compared with patients with higher ejection fraction, higher than 40%. Among patients with ejection fraction higher than 40%, the absence of late gadolinium enhancement predicts very good prognosis over the years. However, in the presence of ejection fraction more than 40% and scar, these patients do worse. Among patients with low ejection fraction, less than 40%, the presence or absence of scar does not add any prognostic importance. Another study showed that among patients with acute myocarditis and preserved ejection fraction, a specific distribution of late GAD plays an important role in the prognosis of these patients. although the most common affected is this inferolateral pattern, in about 1/3 of patients, we can see this anteroseptal pattern that tends to be more mid-wall. These patients had a graded extent of late gadolinium enhancement and a higher left ventricular and diastolic volume. And as we can see here, this was associated with worse prognosis. So according to the recent guidelines, CMR is recommended in patients with suspected myocarditis to reach a clinical diagnosis and to determine the cause of acute myocardial injury, including assessment of edema, hyperischemia, necrosis, fibrosis, and scarring. There is also this new recommendation for follow-up CMR, at least within the first 6 months in patients with myocarditis, to identify a healed or ongoing process for risk stratification and personalized therapy, and to enable a return to exercise. There are not so many studies about follow-up CMR, but on this study from Acquairo show that at 6 months, signs of myocardial edema disappeared in the majority of patients, almost to 84%. LG disappeared in 10% of patients, and its extent in the remaining patients decreased in half of the patients. So at a follow-up CMR in 6 months, we may account 3 different scenarios. First scenario, no edema and no late GAD at the follow CMR. These patients have an excellent prognosis. Second, late gadolinium enhancement with no edema at the follow CMR at 6 months. These patients have a worse prognosis, but we might encounter the presence of late gadolinium enhancement and ongoing inflammation, which means that these patients have the chance of residual recovery, so they have a better prognosis compared to patients without edema. So another important point that the clinicians have to bear in mind is that there is a complex interaction between genetic background and myocardial inflammation that might be responsible for the heterogeneity in the clinical presentation. An inflammatory stimulus of the heart might unveil an increased genetic susceptibility to develop overt LV dysfunction or arrhythmogenic phenotypes. At the beginning, it was only published in small case reports, but now it becomes common knowledge that episodes of acute chest pain with troponin elevation and normal coronary arteries may occur in about 15% of patients with desmoplakin mutations and are associated with late ventricular late gadolinium in about 90% of cases. These episodes might represent hot phases in the clinical history of the disease, or might be also the initial presentation of arrhythmogenic cardiomyopathy in particular. It has also been shown that there is an overlap of genes variants predisposing to myocardial inflammations and inherited cardiomyopathies, namely arrhythmogenic cardiomyopathy, non-dilated left ventricular cardiomyopathy, and these patients might have myocardial inflammation as this is detected by biomarkers or by CMR. So we have to keep that in mind, and we have to raise our suspicion by obtaining a family history, including pedigrees in case of recurrent myocarditis or pericarditis, and even provide them with offer them genetic testing that in cases with definite myocarditis or pericarditis, with recurrent episodes, with persistent troponin elevation, with severe ventricular arrhythmia, or even with this pattern in late gadolinium enhancement, this characteristic Rick-like pattern, or even septal late gad. Lastly, there are a lot of things that should be investigated in myocarditis, including the role of parametric mapping in the follow-up of the patients, the CMR feature tracking myocardial strain, radionomics. In conclusion, CMR has central diagnostic role in acute myocarditis. The updated Lake-Lewis criteria that have incorporated T1 mapping techniques improve diagnostic accuracy. CMR can help in the stratification of prognosis with calculating ejection fraction, the LGE presence, the distribution, whether it is mid-wall or adderoseptal, and a follow-up CMR within 6 months of the decision set is recommended. I would like to thank you for your attention and happy to take any questions.
Dr. Tsoumani, thank you very much for this excellent talk, excellent presentation, delineating the progress that has been, substantial progress that has been done to the clinical management of myocarditis, not only for the diagnosis, but also for prognostication of this difficult field in cardiology. In fact, a new term has been entered by the guidelines that have been released this August, which is called IMPS, the inflammatory myopericardial syndrome. May I ask you, do you use this term already in your reports in the clinical setting?
So this umbrella term is actually used in the initial diagnostic process. So I might put it in the referral region. However, at the conclusion of my CMR report, I will be more specific, saying the form, whether it's only myocarditis, pericarditis, myopericarditis, or perimyocarditis. So I try to be more descriptive. I try to put a form of this syndrome.
Michael, you hear me?
Thank you very much for joining us, Professor Adamopoulos, dear Stamatis. It's great to see you again.
I'm terribly sorry, but my microphone betrayed me, actually. It's my honor and pleasure at the same time to co-chair this important session with a pioneer in myocarditis and inflammatory cardiomyopathies, Michael Nutsias. And allow me also to thank, not only to thank, but also to congratulate Sophia for promoting such an important modality, prognostic and diagnostic, in my country, and why not throughout Europe. So I agree, Michalis, that it's an exaggeration actually by putting the same umbrella to most of the times different entities with different etiology, with different diagnostic tools, with different, most of the times, different treatment. Anyway, Dr. Tsoumani, it was a very informative talk. You underline the importance of ring-like a pattern. Don't you think that whenever we see a ring-like pattern, especially in recurrent myocarditis, this provides a very good indication to check the genetic background? Because if we find desmoplakin, as you very nicely pointed out, desmoplakin mutation not only predisposes to myocarditis recurrence, but predisposes to ventricular arrhythmias also, sometimes asking for either immunosuppression or for ICD implantation. So don't you think that whenever we see ring-like, especially recurrent, we have to seek for desmoplakin or filament C?
Yes, absolutely. This is a very nice comment. Yes, indeed, we are this characteristic pattern of late gadolinium enhancement, the ring-like, is even more commonly, is even more recognized that it has a good probability to suggest that something else is, in terms of cardiopathy, is occurring here. In terms of so the desmoplakin genes for arrhythmogenic cardiomyopathy. So if I see only once, I might say that the differential diagnosis include myocarditis, but please keep in mind that the first manifestation of our ARVC can be this one. If I have recurrent myocarditis, then my conclusion would be strongly suggestive that that genetic counseling, genetic tests should be performed.
Yes.
Because there is a high probability desmoplakin gene mutation to be discovered.
Yes, and some centers with when we have got recurrent myocarditis with desmoplakin mutation, because of the high probability of another episode, go for immunosuppression, isn't it?
Mm-hmm.
Because we might have in the background hot phases, on the other hand, which is sometimes the very first manifestation of arrhythmogenic cardiomyopathy. Anyway, so there is a question, Michalis, from our audience. Yes, how do you manage, Dr. Tsoumani, how do you manage the physical activity cessation after one episode of myocarditis?
So absence from the competitive sports should be encouraged and should be stopped, and any of these activities until we have the biomarkers, the serum biomarkers back to normal values, and after we have a repeat CMR within in about 3 to 6 months to confirm that there is no residual myocardial inflammation. If we have no residual myocardial edema, then ECG treadmill test, 24-hour Holter monitoring should be taken into account to allow the patient go back to the normal activity.
Which activity, Dr. Tsoumani, 6 months later, although LG extent is not reproducible, but sometimes you have got 10, 15, 20% LG extent. Would you, how would you advise the elite athletes to encourage them or to discourage them with quite extensive LG to carry on their competitive sport? It's a controversial area, gray area.
So we need more information, more studies to be done. If it is extensive, you might discourage patients, especially athletes, competitive athletes, to abstain from the sports. However, more tailor-made decisions taking into account not only CMR as Holter monitoring and treadmill tests should be taken into account, and we have to make case-based decisions.
You're right. You're right. Oh, okay, Michalis, we carry on.
Yes, we have to move on also for the sake of time.
Yes.
Dr. Tsoumani,